Salam hormatly ilişkiler. Meni çağıranınız için köp minnettarlık bildiriyen. TASA sempozyumunu Philadelphia'da tayarlandı. Doğan kardeşlere de minnettarlık bildiriyen. Men Kakageldi Hommadov Murvaplı 2003'te Turkmen Türkmek'ten utardım. Ondan sonra Gaziantep University School of Medicine 2004-2011. Sonra İstanbul Bakırköy'de 7-8 ayalı anesteziyoloji ve critical care'de asistanlığa başladım. Sonra Amerika 2012 sentyabrda geldim. Bir yıl research. Ondan sonra asistanlık journey. We'll talk about a little more throughout the presentation. Ben presentation İngilizce edecek onun yönü arada Türkmence düşünüşlere de geçip biliriz. So we're going to talk about medical education in the US and in comparison to a European system. Medical education. So admissions to medical school in U.S. requires undergraduate degree from an accredited university, and usually rigorous coursework is required in physical sciences, chemistry, biology, math, and physics. And there is an exam called Medical College Acceptance Exam called MCAT. You have to take that exam in order to apply for medical schools. You don't necessarily need the biology or chemistry degree. However, during that 4 years of college, you're required to take the prerequisite courses for medical school, and each medical school has their own requirements. But basically, the common ones are, biology 1, biology 2, chemistry 1, chemistry 2, and then labs, physics, and math. Since the U.S. medical degrees are considered the second entry, like a graduate degree, and there are two routes to go for medical school. One is the MD, the allopathic one. The other one is DO. MD stands for medical doctor. DO stands for doctor of osteopathic medicine. So, like the DO schools are. How many DO schools? I think they're less compared to MD schools in terms of the numbers. However, the DO physicians are equivalent to MDs. In addition to regular training in medicine, osteopathic doctors, their philosophy that they believe that the body has inherent ability to heal itself, and they are trained to use their hands to perform manipulations on the patient that will help facilitate the healing process. Just to give an example, rather than offering a patient Advil for their back pain, the osteopath will attempt to fix the source of the back pain with some manipulations. So medical schools in the U.S. requires mostly it's 4 years. First 2 years you do go through the preclinical courses. And third and fourth years, you do clerkships. And the residency application takes place in fourth year of medical school, and then the interview process goes throughout the year. And towards the end of the fourth year, the residency match gets announced. So, board exams. So these are the exams that U.S. medical students are required to take. And if you're a foreign medical graduate like me, you also require, and if you want to do residency training in U.S., you also require to take these exams. Step 1 is basic sciences, preclinical course that U.S. medical students learn in first 2 years of medical school, and by the end of the second year, they are required to take USMLE Step 1. And the Step 2 has two different exams. One is CK, stands for clinical knowledge, and CS stands for clinical skills. So you are required to take those Step 1, Step 2, CK, and CS in order to apply for residency. And Step 3 is you take it during first year of residency training. it's more advanced clinical exam and clinical management. So the CS you take, it's a mock physical exam type examination, the board exam. So you go see 12 different patients back to back, and you have like 10 minutes to examine the patient and take history, and another 10 minutes to dictate your note and order tests and diagnose what their disease is. And the step 3 is a little more advanced. I'm not going to go into too much detail about that. So, as I said, the U.S. medical students take step 1 at the end of the second year. Step 2, the CK they usually take during third year, towards end of third year. CS they usually take it in fourth year. So in order to apply for residency, you don't necessarily need CS. However, in order to match, you need CS exam. So by the end of the medical school, you are supposed to take first 3 of those exams, except step 3. So, as we mentioned earlier, fourth-year medical students are qualified to submit their applications for residency through the online portal called ERAS, Electronic Residency Application. It stands for something like that. Majority of the fourth years complete their audition rotations at desired programs, which means that let's say if I want to match to UPenn radiology, in fourth year of medical school, I tried to get rotation at UPenn, so they know you better, so you can get the interview easier. That we mentioned about the interview season. So in September of each year, I think it's September 15, you submit your application. You write your personal statement about why you want to choose that specific specialty, and you need the dean's letter from your medical school, and you need at least 3-4 recommendation letters from desirably U.S. doctors. And the match day. So it interviews, let me talk about the interview season. So you submit your applications, and the programs review your application, and if they like your application, they extend interview. So then you accept the interview, you go for an interview, and after the interview, if they like you, they rank you. If not, they don't rank you. So let's say you rank the program for number 1, and they ranked you higher. In March, there is a system, online system. You submit your rank list, programs submit their rank list, and if they match, if they rank you higher and then you rank that program higher, you end up matching there. If your first, let's say, if your first option doesn't work out, then second option, third option. So this system goes like that algorithm. And the internship, which is the first year of residency, it starts on July 1. So if you guys are sick, don't get sick in the first few weeks of July, because everyone is rookie in the hospital, especially in teaching hospitals. So first year of residency training, trainees are called interns, and more senior trainees are called residents. So duration of residency training, so for medical, internal medicine, pediatrics, it's 3 years. But if you're going for another specialty, it differs. For example, for anesthesia, it's 4 years. Radiology, 5 years. Surgery, 5 years. If you go for neurosurgery, it's about like 7 years or something. And once you complete your residency training, then if you want to subspecialize, let's say for internal medicine, you can subspecialize in cardiology, gastroenterology, oncology, nephro, infectious disease, whichever that you want to you prefer. You go through application just like the residency application on ERAS. You submit applications for fellowship, and you end up matching. So fellowship programs are it depends on what fellowship you go into. For example, nephrology, it's 2 years. cardiology, it's 3 years after 3 years of medical residency. So after completion of residency and fellowship, physicians take specialty board exams, and then after that, if you pass that, then you start practicing medicine independently. So once physician completes residency training, they've been studying and training for minimum of 11 years before they start practicing independently. So what U.S. residency program requirements for FMG stands for foreign medical graduates. So you have to graduate, you have to have a medical degree from recognized university. So there is an ECF, there is a society called ECFMG. I think that stands for Educational Committee for Foreign Medical Graduates. So they assess medical schools and their curriculums around the world, and then they okay, this medical school is good, this medical is not good. So if your medical school is in the list of that schools that are accepted by ECFMG, then your medical degree is considered credible in US, and then you can, if you desire to pursue residency training in US, then you can go for it. So medical degree from a recognized university, competitive medical school transcript, you got to get dean's letter from medical school, and it has to be translated in English. US clinical experience, which they require, mostly they tend to favor for more hands-on clinical experience rather than shadowing or observerships, and recommendations letters from US physicians. And once you take those exams that I mentioned earlier, you get ECFMG certificate. That means that your medical degree is now equal to US medical school graduate's degree. Then you can apply for residency training. All right, so let me talk about a little bit of match. So I pulled this data from match data from 2019. So total available positions for residency spots, around 35,000. Total number of PGY1 positions, which means that it's a first year position. It means postgraduate year one. It's about 32,000. PGY2 positions, that's like, let's say you did your internship, 1 year internship somewhere, and now you want to go for radiology, then you apply for advanced programs in radiology. That's what it means for. Reserve positions, it's something, let's say you trained in one specialty, like me. I finished my internal medicine, and I'm applied for anesthesia and got into anesthesia. So I'm going for a reserved spot, because it means that you're already a physician in one, trained in one specialty, going for another specialty. So these are very limited spots. Only 236 in 2019. So total number of applicants, almost 65,000. Almost half of them are US medical school grads, and the other half is foreign medical grads. So total number of matched this year was 33,417, and almost 20,000 of them were US seniors, which means that US medical school grads, and total unmatched is almost 30,000. So out of people who applied for residency, 40 to 45% of applicants end up not matching. So usually what ends up happening is US grads have a higher chance of matching. Almost 95% of them match to first year positions. And foreign medical grads, their graduates are usually divided into two. So they're the American citizens who couldn't get into medical school here in the United States. Some of them end up going to Caribbean medical schools, or going somewhere in Australia or somewhere in Europe, and they come back and apply for residency. So those people are called US IMGs, US International Medical Grads. And people like me who are not US citizen and who was trained in medicine in some other country, are called non-U.S. citizen IMGs. So it's a kind of similar percentage, almost 55 to 60% of U.S. IMGs and 56 to 57% of non-U.S. IMGs and ended up matching the PGY1 positions this year, and 85% of osteopathic doctors, medical school grads matched to PGY1 positions in 2019. So it's a rigorous process, and not everyone ends up matching. And the foreign medical grads have more disadvantage compared to compared to U.S. citizen foreign medical grads, because they don't need visa, they have family support, they can easily take on non-paid positions to enhance their CV to make it more competitive. For us, sometimes it becomes it's a difficult process. So financial burden. Steps are expensive. The total, you end up spending like $5,000 with those prep books and online resources and whatnot. Practice exams ends up being like $6,000-7,000. So if you are coming from other country and trying to get into residency training in the United States, usually you don't have any prior U.S. healthcare experience. You don't know anyone, any doctors. You need recommendation letters. You can't just get a recommendation letter just shadowing someone for 2-3 days. So you have to, put on a lot of work. You have to take on some unpaid positions, do research, and do some observerships and whatnot. So you need to spend. Some people end up being lucky after a year. They get in. Some people need 3-4 years. And if you are a medical student, while you're a medical student, and you know that you want to you want to apply for residency training in the United States, if you take your Step 1 exam during medical school and during clerkships, you can come and do a month or two clerkship rotations in the United States. That is the ideal way. You apply, and some medical schools accept foreign medical students for clerkships, and then you can spend a month in the United States, go to the hospitals, around with the attendings and residents and other medical students, and get some hands-on clinical experience. That's considered very valuable. And for foreign medical grads, since it's more competitive, you end up applying to 100 and 150 programs, and on ERAS, each application is like $25 or so. So depending on how many programs you apply, you end up spending quite a bit of money, and interview travel, hotel stay. So you need rich parents. So my journey abroad. So I mentioned that I graduated from University of Gaziantep Medical School in 2011. Right after graduation, I took my Step 1. In February 2012, I started anesthesia residency in Istanbul. But back then, they weren't paying foreign medical grads in Turkey. So you were working 80 hours a week, and and you're not getting paid. So it was hard. So I decided to take a Step 2 CK during residency, and September 2012, I came to U.S., and that's me boarding. I was young back then. So my journey in U.S. So I did unpaid research at Ingalls Hospital and Medical Center in New Jersey. That was a part of anesthesia and critical care department. We did research about bloodless medicine. In 13, I took CS exam in Houston. So 15 year, I applied to anesthesia residency programs. Anesthesia is more competitive for foreign medical grads. So out of 100, I got 2 interviews. I wasn't able to match that year. So in 15, I did some clerkships, and this 15 to 16 year, I applied to internal medicine, got like 5 interviews, and I matched. So like what happened in first year and why I wasn't successful, I didn't have clinical letters, and I didn't have clinical experience in US. All those letters were from observerships and shadowing and whatnot, and research, so they were considered not that powerful in terms of your application. So I am internal medicine. I thought it would be easier than anesthesia, which it was, and I thought I would go for internal medicine 3 years and then do pulmonary and critical care fellowship afterwards. So I had to redid my personal statement, and so people who are coming from outside of the U.S., they don't know the interview process. You know, we're not very confident when we go to interviews, and we end up giving cliche answers. You know, they tell you, it's like they ask you, what is your like strength? And you tell them, oh, I'm hardworking, I'm a team worker. But you have, like everyone says that, you know, you have to give them more personal background, personal answers, and you have to be confident. So those people are very experienced in interviewing. They interview like 300, 400 people every year. So like you have to be confident, not seem cocky. In the meantime, be respectful. So like it took a lot of extensive interview practice. Then let me throw some pictures. This is us in Englewood Research Department, and this is me when I start residency. That's the graduation from a few weeks ago. That's our program director, Dr. Eric Green. So in terms of journey timeline, so 2016 March, I matched the internal medicine residency at Mercy. It's right outside of Philly. I finished I finished internal medicine residency a week ago, and this March I matched the anesthesia residency at Temple. On July 1, I'll be starting there, and that's another 3 years. So August 2019, I'm scheduled to sit for board examination in internal medicine, and after that I'll be board certified in internal medicine, and I can start practicing medicine independently. June 2022, plan to complete anesthesia training, and then followed by board certification exam. Then it's hopefully in end of 22, I'll be dual certified. So this is that's the presentation about U.S. medical school and residency training. In Europe, you don't go for undergrad. You directly go for 6 years of medical school. But you know, in case there are a lot of young Turkmen guys in U.S. and who then a lot of parents probably, some of them are considering that sending their kids to medical school. This is how the system works. So we're going to do some a few more slides about cardiovascular diseases, and you guys can interrupt me if you have questions about the U.S. medical school training and residency training in U.S. Any questions about that? Yes. Turkmenistan'ın Med Institute'u kabul edilen ok. Azerbaycan Bakü'nün kabul ediliyor. Orsiyette cover institutlar kabul edilen ok. Köp Orsiyette köp kabul ediliyor. Yani sonra teretmella hayse şu portalda sen Gutoran Medical School'un is it recognized or not? So there is a national portal like that, and there's also certain states. For example, Texas doesn't accept anything, any medical schools from any prior SNG devletlerinin hiçbirini kabul eden yok. California Sholoreale, New York State Caribbean School or Kabuledanok. Being bildiğim bilişime göre Türkmenistan'ın medin stüdyo son gutoran olsan da karıştırdıktan sonra kabul edilenok. Ve ne için residency training için you need to be there is some since it's so competitive there's a lot of applicants applying. They tend to favor recent graduates. So you had to be recent graduate within the last 5 years. If you are like in your 50s and you're moving to the United States and you were orthopedic surgeon in Turkmenistan, you want to do residency training, it's impossible. No one will take you. But let's say if you were a professor over there and if you were very well known and if you have like hundreds of papers, then you can get it like an academic position. But if you're like regular surgeon, it's hard to get. And usually if you're foreign medical graduate, the big university programs are not foreign medical graduate friendly. And if you want surgery, it's harder. If you want like cardiovascular surgeon, it's almost impossible to get. You see, they tend to give those positions to U.S. medical grads, and the number of positions are limited. So, and since the U.S. medical grads end up having almost $500,000 debt, and those positions are paid well, so they tend to give those positions to U.S. medical grads. Türkçe okudum ama. In terms of medical literature is the same, you know, like medical textbooks are in English, and then the exam prep books are in English. So in terms of doing questions and understanding what the exam is asking, it's not too hard, but in terms of speaking, yes, it is a little bit hard in the beginning, but you have to push yourself, you have to be uncomfortable in order to learn, you know, navigate through the system. But it takes some time. Benim Türk mektepten alacak İngilizcem vardı. Yani gepleşmek nemesindeken ilk başta kıyınçılık çeken bir küçay, ondan sonra açılık gidiyor.
Hindistan'da ya da Türkiye'de practice edip gören doktor, günlüğüne yaşayan patient görüyor, Amerika'dakiler sonuçta gören o, sonuçta o tarafın doktorları more experienced, better the argument. Would you agree or disagree with that assessment?
So it's in terms of like you need to spend some time with patient. If you're seeing a patient and spending like 2 minutes for one patient, you're going to miss a lot of stuff. And so their standards are not that high. For example, Türkiye'de kan knowledge işler atıyor kan diyelim 60 tane hasta var nemede araştıran 3 tane doktor var. İyiliğini göreyen hemmetini onun berde hemmedat sistematik işleye Türkiye'de ya da Hindistan'da malpractice problem yok. Berde malpractice problem var. Onun berde işte demeler a lot of restrictions are in place from your hospital, from your residency program, and for a new patient, you're required to spend at least 30 minutes to 45 minutes. If it is an established patient to follow up, let's say you're coming to my clinic, I already know what your medical history is, and I know that what you're here for, so I don't have to address all the past medical history. I just address why you're here. Let's say I'm adjusting your blood pressure medication. You come in with the blood pressure log from home that for past week, I know what your pressures are, and I know what medication you are on. If I want to increase or decrease it, I make that decision. and then I don't have to do full examination, only pertinent stuff, and within 10 minutes you will be out of the office. So it depends. So in terms of surgical experience, some doctors over there, let's say outside of United States, foreign doctors, if they've done thousands of one type of surgery, yes, they will be more experienced than a new doctor who just graduated from here. But the medical advances over there, they're not trained to do the new procedures. For example, the place that I'm going for anesthesia, they're #1 lung transplant center in the world. So I will be, let's say, when I'm on call, I'll be going to transplant surgery and doing anesthetic care for patient who's on transplant, who's on bypass machine. So like those stuff, people in India don't see, people in Turkmenistan don't see that kind of surgery. So there's like trade-off. I think the medical advances, whatever it's found in new in medicine, it happens in United States, and you learn on first hand, and then other places, it goes to other places. I'm not sure if that answered your question satisfactorily much. Biz nähili kömür edipler solara şomu soru. Biz şu at Türk olanlar var yesek tane önemede New York'ta Boston'da biz Philadelphia chapter'ına açtık White Tulip diye bir organizasyon var. Şol mentorship program var ya Türkiye'den gelen medical school graduate'ları berderişten ahili sistema entegre olmalı, egzaminlere nahil tayarlanmalı. Men tayarlarımda practice, USMLA World'li practice deme var portal. Ondan havarmam yoktu, onu almasan egzamini geçip böyle oken. Men havarım yoktu ondan. Tayarlanan kitabla 2004'ün ki bir de hani diyelim bir de bir yol orkadan bir bolsa değil ilk başta. Men USMLA stepper'ım go tayarlanan olsadım, has ulu baha alan olsadım birinci yıl yerleşirdim belki. Şolar yani mentorship gerek o ne Türkmenler için yankıyalı şu white tulip muhtemelen bolayamasa bilmedim de köprek san gerek bizden Türkmenlerden. Olmasa edil Türkmenistan'ın beri gelmek isteyene hiç bize demeden olmadı. Yani Türkiye'den sonra yarlar şu an Türkmen olan var patolojide research'a geldi Pittsburgh'da. Men Türkiye'den Gayet Bankam ol yana başlattı tanışıptık. Şöhretliydi herhalde. Şu an Pittsburgh'da ol erik yerleşecek ol ya. Şolar yani gelenler kömek sorusalar ediyat olmasayken neme yok edil ofisyalne. Belki Facebook'ta var grup olur hani ondan sonra tayda öde e-mailini nemeni paylaşıp şolar yani burada atlar edip olur. YouTube kanalım yok onun belki duran Avustralya. Başka soru? Berden yalı deme yok hani Berde mesela gospitalda götürdün ha mesela birden 8'de başladın 5'te götürdün 5'ten son you carry pager küçücük page ol 80 yıllardan kalan pagerler var bir tane de bulun ya sonra. Şol açık işte vaktin songa thanga problem was the pager dan zanga dialar on best the en gutordanga pager ng yap yang best and thong awsam isle and doctor lorwa then hat patient lang songa idyang na thing thanga gelen pager lang hemmet in olor jawab karon ir den geleng de thanga email ya şu patient zangatti real problem atwa şunu şeyttim bunu beyttim deyip thanga sign out dialar gije hiç kimtene bir rahat edenak. Amerika'da mı? Jail. Yeah. Amerika'da licensed bolanak. Berde jail, licensed practice in jail. But I'm here 10 yılla board certification tadil attırmalı. Diyelim Turkmenistan hani könüde oradan alan doktorlar var 60. yıllar meri practice etbörünler. Olar han tadil dermanları bilen oklar. Şu ad hepatit C Turkmenistan adamlar ya Afrika'da adamlar hepatit C'den ölüyor. Berde hepatit C 100% tedavi edip oluyor. Hemmeti becergesi bağ yani. Tadil dermanlar var. 99% ehli genotype'ları öldürüyor. Biz o dermanları bilen oklar. Ne edip bilirsin o dermanları? Her yıl şu tadil çıkan literature okuyup görsen biliyorsun. Vaktine berde licensing'i aktive edip tutma için var. Yıllık continuum of medical education deyip bir kredi almalı her yıl. Diyelim Grand Round, Solya Hospital'la attending doktorlar var ha. Gelip şuna katlaşıyorlar. Her katlaşanına sen 2 point alıyorsun. Onun yılla sen 50 point, for example, 50 point alttırmasan sen state medical boards, they don't continue your board certification. So yani ödün update tutturmalı.
One last question: is it all worth it?
I don't know. It's maybe I can answer the question in 10 years. It's maybe 5 years. It's been hard. Financially, it's been hard. Credit card'ın canı sağ olsun başka ne yapayım? Kıyın yani yaman. Yani en esası zaten fail. Ang görküş bir 45% yerleşilen o. The most important thing is like not to give up and push. You know, what did I do wrong? What was my application? What part of my application was weak last year, and what can I do to improve? Bilen birine hükman maslahat etmeli başlaman kan. Bram neme gerek da adını tenayt. Moralny ve financial support important. It's worth it afterwards. So if I sign a job right now without going for anesthesia training as internal medicine doctor, for a year I think it's you start with at minimum 220,000 a year, and it goes up to 250. If you do anesthesia training, and if you become an anesthesiologist, general anesthesiologist, you start with 300,000 a year. If you end up doing fellowship on top of anesthesiology, let's say if you do cardiothoracic anesthesiology, you start with 400, 450. If you do pain fellowship, you start with 500. So it depends on what subspecialty you do. Yeah, you're going to be in training until like 40 years old, but afterwards, in terms of financial situation, I think it is worth it, but I don't have that much of money right now, so it's hard to tell. Huh? Then you could retire early for sure, yeah.
Have you thought about working part-time in your, whatever that you just got?
In medicine?
Yeah, and then like studying part-time in the second one that you were pursuing.
And so during training, it depends. First 2 years of residency training is hard, so you don't get a whole lot of time off, and you have your own responsibilities from the program. And if you're performing well, and if the program allows you to, which they call it moonlighting, which means that you can work outside of your residency, you're allowed to work doing private shifts. Yes, you can. Right now, in our hospital, in medicine, we are allowed to moonlight over the weekend. If you don't have weekend shift, you can pick up a shift, and you can make like $500, $600 in 10 hours or so. It's not too bad, but it's tough. You have to have a better, let's say, if you're on a hard rotation, it's hard to do it because you work, the requirement, the time you have to be in the hospital is a lot. But if you're on an elective rotation, it's a light month, light schedule, yeah, you can pick up those shifts. Medical bill olur. Bill onwara U.S. health system is based on that. It's like private insurance. There are a lot of private insurance companies. European system yal social neme yok da health insurance devletin. Ondan nem var ya bilemem. Diyelim sen klasaşın gitti $70,000 bill geldi appendicitis için. Sen klasaşın $70,000 tölen ok. Ondan diyelim immigrant biri gitti acile bar neme nol çabardı diyelim pneumonia için hospital'a yatırıldı 3 gün sonra discharge oldu. Ona geliyor $50,000. Ondan on insurance ba diyelim. Insurance ba on insurance töle ya. Ondan insurance bolmayan milyonlarca adam mı? Olar ne olacak geliyorlar. Olar iten hospital ya doktor sen insurance'ın yok sana kömek edecek geldi bilen oklar legal ne. Ondan ne oluyor? Şol insurance bolmayan garip adamlar tölep bilen oklar. Ondan tölep insurance bolanlara da ekstra charge ediyorlar. Şöyle yapmak için. Sistem şon yali yönü American. Is it good? No, it's not. Is Canadian system good? Yeah, it's good. Men fikrimce nahil olmalı. Preventative health, like medical stuff, should be free for everyone. Diyelim, sen gidip yıllar gerek doktoru general check-up için görüp bilmeli. Diyelim sen şeker keselin var, insülinini alıp bilmeli. Ben fikrim şun yalı olmalı, onun ay, demede yaman köp politika dağıtlar var, bu insurance company'ler, what they end up doing is all the politicians, their campaign finances are, they support all those politicians, and when they're in Congress or Senate, they don't vote against them. That's the issue. Nong senyal menyallar safredyada. Huh? Malpractice also. Other diyelim malpractice hem şon yaltın insurance'ın ha diyelim birine yanlış medication verip bırdat bollu diyeli. Ondan they don't go after the nurse who gave that medication. They don't go after physical therapist who assessed the patient. They go after who's making more money out of them. Oh, doctor. Okay, let's sue the doctor. Let's sue the hospital. Ondan olan hemmeda de nemesvada. So liability insurance, malpractice insurance, then in order for you to practice as an attending doctor, you have to have like malpractice insurance. You have to pay for that. That's like hundreds of thousands of dollars. The system it's not perfect, but we don't have a whole lot of power to change it. Maybe when we vote for politicians, we can. I don't know. Maybe Bernie will come and fix it. Do we have time for the other one? The cardiovascular disease so it's common in general population, affecting majority of elderly population. The cardiovascular disease is estimated 17.3 million deaths annually. So the 4 major categories: coronary heart disease, which is heart attack, cerebrovascular disease, stroke, insult, peripheral arterial disease, any blockages of your arteries in the legs, arteries in the arms, usually in the legs or maybe in the carotid arteries. And aortic atherosclerosis, big aorta damarwag, yurong chikyan, shong tikanik shong daral mathia, aneurysmalar, yang aorta damare, she go through the she legit get asak garnung dan gelip ayak lang at gidyada. So garnung için the chest cavity the bolon aneurysmalar. So it's divided in 4 major categories. So lifetime risk of overall cardiovascular disease approach 50%. A lot of us are young and they say that, oh, we don't have any risk factors, but in lifetime history we're going to have one of those diseases. Even at 30 years of age. Yeah. So cardiovascular risk factors. So the major modifiable risk factors are hypercholesterolemia, cholesterol can mathi demada gan lipiding couple mathi diabetes, sugar hastalığı, hypertension, diabetes, obesity, and smoking. We all know. So family history of cardiovascular, coronary heart disease. Thing maşkalang da yaş genç Türkmen yaşlıkta eğer diyelim enen atangdan ya da doğandan first degree relative and your parents, if they had heart attack in males in the before 55, in females before 60, then that's an independent risk factor, even if you're 30 years old. So coronary artery disease, şunla görkez William kam cursor burada. Şol yukarıda şeyle giden damar var, şol aorta damarı. Şu gadal. Ol gök olanım inferior vena cava. Şu yürekten ana 2 tane şey gadal damar gaydara aşak 2 aptalından. Şollara coronary artery değil ya. Şol damarlar yüreğe gan ve oksijen nutrient ediyen damarlar. Hani onların aortadan gaydya. Ondan nemolya coronary artery disease. The first picture on the right top is normal coronary artery. İkincisi it start getting atherosclerotic. You see the tharadatlar var ya, sonra atheron plaklar değil ya. Ondan hani olam uje blockage neredeyse 90% block. Ondan atherosclerosis, it's technically the hardening or clogging of those coronary arteries, build up of cholesterol and fatty deposits, and those arteries become stiff and they can't get, they lose their elasticity, and when your heart is pumping harder, let's say when you're exerting yourself, when you're playing soccer, your heart needs more blood. And those coronary arteries cannot supply that blood, and you get a heart attack that way. So without adequate blood supply, the heart becomes starved of oxygen and vital nutrients it needs to work properly. So then you get chest pain. That's called angina. So the portion, so there are like 3-4 coronary arteries, and it has branches all over. So depending on what location it is, the part of that heart that is being supplied with that blocked artery gets damaged. So if the blood supply portion of heart muscle cut off entirely, or if the energy demand of the heart becomes much greater than its blood supply, then that's when you get a heart attack. So heart is the leading cause of death. Did we talk about angina? No, we're going to talk. Heart is the leading cause of death among men and women in United States. 16.5 million Americans have coronary artery disease, and American Heart Association estimates that every 40 seconds someone in the United States is having a heart attack. With no heart. So lifetime risk of cardiovascular disease is 3.6% in men, These are young people, and the 1% for women. Having 2 or more risk factors increase lifetime risk of cardiovascular disease to 38% in men and 18% in women. So premenopausal women, because of the estrogen has protective effect on the heart, but once it's postmenopausal at the age of 70, men and women have same risk, almost it's equal risk of cardiovascular diseases. We're going to talk about this angina. What kind of chest pain is worrisome for, what kind of chest pain is coming from heart, what is not. So angina pectoris is the medical term of that chest pain. Angina means pain, pectoris means döş in Latin. So it occurs when heart muscle cannot get as much as blood as it needs, and usually happens when one of those coronary arteries is narrowed or blocked. So if that blockage is ongoing an issue, and if you cannot fix it on time, in time, and it goes to the ischemia and then infarction progressively. So what is angina? Usually you get uncomfortable feeling in your chest. It's like, oh, döş in the pilotroniale. You ask, can you locate, which location it is? They can't pinpoint it. Sure, no. It's the whole area. Usually they're sweaty, they're short of breath, they're anxious, they can't describe the exact feeling, they feel like they're going to die soon. So ölüm korkusu oluyor, they feel nauseous, sweaty, sometimes dizzy. So these are the typical symptoms, and it's worse with physical exertion, it's worse with emotional stress. Sometimes when you take nitroglycerin pill, it's like sublingual under your tongue. The nitroglycerin, what it does is it just dilates that coronary arteries, and then you get a little bit of more blood supply than usual, and you get a little bit of relief. Sometimes that chest pain can radiate to your jaw, to your left arm. Those are typical angina. So in women, it can be different. They can present with like more reflux type syndrome. Oh, I feel like I have, there's a discomfort, but it looks like indigestion, or it looks like reflux. So the studies have shown that, the physicians miss more heart attacks in women compared to men because they present atypically. So you have to have low suspicion for coronary artery disease in women, that you should know that they can present a little differently, especially women with diabetes, they present differently. So I think we talked about it. Relieve the rest, yeah. We talked about this one. So what is acute coronary syndrome? So yankı angina değil, yani ol köpülünç bolya diyelim, 60 yaşında her yerde when you mow your lawn, you get that chest discomfort, and when you sit down it goes away. So that means you have stable angina. So acute coronary syndrome, what is unstable? So these three are part of acute coronary syndrome. Unstable angina, when that you're stable, let's say that chest pain that you get when you mow your lawn is now more severe, lasting longer, coming more frequently. It means that that plaque, the blockage is becoming unstable. Maybe that a small amount of little plaque is ruptured and going down further down and blocking the tip of those arteries. So this is, it may relieve with medication, but still it is a medical emergency. There is a high risk for progression of the real heart attack. So NSTEMI, which means that non-ST elevation MI, the EKG'de var, demet koyup çektiren kardiyogram. Sonraki demelen wave'len birine ST segment değil ya. Karoçum şloriyali chest pain ile geliyen, there is no EKG changes, your cardiogram looks okay, but when you do blood test, there is a spillage of cardiac enzymes in the blood. Those are going up, and you have typical symptoms. That is NSTEMI. STEMI you have typical symptoms, you come to the ER, you do EKG, and there is EKG changes that's suggestive of heart attack. And that's, so bulan 3 tane de heart attack, 3 tam heart attack deyip kabul ediliyor. 3 şeklem. Which one is more severe? The one in the below STEMI is more severe. You have to go to the cardiac catheterization within 90 minutes of arrival in the hospital. The other two, you will still need cardiac catheterization, but it can be delayed. So risk factors. This is risk factors for coronary artery disease, modifiable, cigarette, cholesterol, high blood pressure, diabetes, which is uncontrolled, let's say physical inactivity, being overweight, and uncontrolled stress and anger. The overweight thing, I put a little note about weight distribution. It's not necessarily if your BMI is like, let's say 32. Yeah, you consider obese, but the weight around your waist is a more risk factor. So, şoň üçin erkek adamlar üçin belli bir limit var, ayal maşalar üçin belli bir limit var. Şoň üstüne geçten it's increased, it gives you increased risk for coronary artery disease. Şoň üçin pear-shaped men, they have higher risk for cardiac attack, heart attacks. So weight distribution, bilin kenarındaki kenarındaki weight is a risk factor. So non-modifiable, if you're male, too bad. If you, especially after 65, age is important. Family history. So race, African Americans, Mexicans, and Native Americans have a higher risk of coronary artery disease compared to Caucasians because they tend to have high blood pressure and they tend to have more diabetes compared to regular people. So prevention, exercise 30 minutes. You don't have to do marathon, but 30 minutes rigorous walking, jogging. Choose the exercise that you enjoy. Diet. Yeah, diet affects a lot of those modifiable risk factors. Smoking cessation and regular doctor visits to manage your underlying medical conditions. So food, which we should choose. Plant-based food. Why? Because they have less cholesterol, high fiber, nuts, olive oil, olive oil. Certain fish, because it has hearty omega-3. And the food that we should limit. So the bad cholesterol is called LDL cholesterol. It comes from meat and dairy products. So we should eat less shore and less whole milk and other source of saturated fat. No margarine. Turkmen margarine. So, and also like things that more vegetables, more fruits. Stay away from drive-through McDonald's. And typically non-whole grain is more healthy than the white bread. And also salt. Salt increases your blood pressure and water retention. So taking less salt is helpful. I think that's about it. Oh, this is my white family. Any questions other than my white family? Yes. Coronary heart disease. Once you have it, it's chronic. So, diyelim blockage nehil tedavi ediyorlar onu. Coronary diyelim yankı hali sen chest pain ile hospital'a gittin. One of those three you fit into one of those categories and you end up going for cardiac catheterization and they found that one of your coronary arteries is blocked. Then what they can do is they can put a stent there or they can do a balloon angioplasty. What they do is they go through your groin or the wrist and through the artery and they go to the aorta. From the aorta they find out those coronary arteries and they go into that coronary artery and they find the blockage and they can put a little balloon there and gaz air verp yank balloon chishriyalar yank narrow volunyer açılyaracık. If not, they can put a stent there, and then after that, you end up being on 5 new medications. If you have 3 different coronaries, all of your coronaries are clogged, then you will need cardiac bypass, which they do. That they find your they take one of the veins from your leg, and they crack open your chest. They find that coronary artery. They put the bypass there. Let's say there's a 1 second. Let me find out that coronary artery. Let's say there's a blockage somewhere in the middle. You see that little rectangle place? That's where the blockage is. So they take the graft and put it on top of that and bypass there. So the top of the graft, one tip of the graft will be proximal to that. The other tip will be the distal to that blockage. So that way you bypass that blockage. So that's how they treat it. Any other questions? All right, thank you guys.